So let's get started this morning with part 2 of New Drug Update. Our objectives for this lecture, our objectives are to continue our discussion with new medications. Now, these are the ones that I'm going to present this morning that have been approved in the last few months. We're also going to shift gears in the middle of this program, and I'm going to give you new updates on immunizations and new boxed warnings, new products that are coming over the counter so that you are aware. So my references are either on the slide or are at the end of the program. I will say to you that in all of the guidelines that I work in primary care, and by the way, for those of you in primary care, there are 6,000 guidelines for which we are responsible. So when people say to me, what is it that primary care does anyways? We're reading guidelines. That's what we're doing. And we're trying to keep everything together. I don't know if any of you saw the announcement yesterday that came out from Mass General Brigham and Women's Hospital out of Boston. Did anyone see the news that came out yesterday about primary care? They have decided to shut all primary care practices, to not allow any new patients to enter into any of Mass General Brigham and Women's Hospital primary care because the primary care network is so overloaded and they are not allowing any new patients to come into that primary care network. To me, that's heartbreaking. I know in my clinic, we're growing at 150 new patients a month. And while that may sound like not a huge number, the average new patient garners about 3 to 4 visits a year. And the average NP panel in my clinic is about 1,000 patients. So that means every year I'm filling an NP's panel, which is just an unsustainable model in terms of mentoring, training, et cetera. So of all of the guidelines that have changed the most, it's asthma. And I don't know if you've been following what's going on in the world of asthma, but when the GINA guidelines came out in May of 2022, it really turned the asthma guidelines on their head. And so much of what we've done now for the last 40 years in managing patients with asthma is out the window. So that's what I want to spend a few minutes speaking with you about. We're going to cover asthma in detail tomorrow, but this next drug is going to set the stage for those new changes in the guidelines, and I'll present those to you. So in January of 2023, an inhaler was approved. It is a combination of albuterol, a short-acting beta-2 agonist, and the drug called budesonide. You've been using budesonide for years. Many of you know of it as Pulmicort, right? So it's taking both of these entities and putting them into one inhaler. Why? Because the GINA guidelines now propose that no one should be using albuterol any longer as a monotherapy drug. That even for people who have exercise-induced asthma, that if they are going to use albuterol, they need to chase it with an inhaled corticosteroid in some capacity. I will tell you that when those guidelines came out, we started the process in our clinic of educating the 500 people who have been diagnosed with asthma. And this is a time-consuming guideline change because a lot of these people don't understand, why can't I just use my albuterol alone? So this inhaler is kind of one of the solutions to the new recommendations that you never use a short-acting beta-2 alone. And the reason is because if someone needs a short-acting beta-2, it's a signal that there's likely inflammation in their airways. And we know that this does nothing for inflammation in the airways, but works just to bronchodilate. There's also more emerging evidence that recurrent use of a short-acting beta-2 increases the risk of asthma exacerbations. And last, there's mounting evidence that systemic corticosteroids have cumulative impact. And that when people ingest 600 milligrams of prednisone, for instance, over a lifetime, 600 milligrams, you do the math. If someone's having an asthma exacerbation and we put them on 60 milligrams and we do that, let's say for 5 days, twice in their lifetime, their risk of diabetes, osteoporosis, depression, anxiety, and thrombosis all increase cumulatively over their lifetime. So the whole purpose is to find a way to prevent exacerbations, to prevent oral systemic corticosteroids, and to reduce the risk of asthma-related death and hospitalization. There continues to be up to 3,000 deaths in the United States related to asthma every year. And the majority of these patients have never seen pulmonology. They have never seen asthma and immunology. They are managed in primary care. So we've got to start thinking about changing our treatment. So this is just one option. Tomorrow, when we do asthma, we'll talk about SMART therapy, single maintenance and reliever therapy, which is really becoming the norm these days. So here's its indication. It is indicated as needed treatment for acute bronchospasm. So when they feel the need to need an inhaler, it's indicated for that. But it's also indicated for the prevention of bronchospasm. So in these clinical trials, there were patients with exercise-induced asthma who said, the only time I ever use my albuterol is before I exercise. This is an inhaler that can be used in that capacity as well. And last, it's indicated to reduce the risk of asthma exacerbations in adults only. As of today, this inhaler is not approved for pediatrics. Pediatric patients were actually studied in the clinical trial, but the numbers of children in the trial for this inhaler were so small that while there was statistically significant effect, the numbers were not high enough that the FDA felt comfortable authorizing this for children at this time. So there are ongoing studies. I do expect over time you will see this inhaler become indicated for children, but as of today, it's 18 and older. So they're going to get 180 micrograms of albuterol. They're going to get 160 milligrams of budesonide in 2 puffs. And it's the same utilization and dosing as you do when you're giving people albuterol alone. So it's 2 puffs every 4 hours as needed, not to exceed 12 puffs in 24 hours. So because it contains budesonide, the biggest side effect that we saw or adverse events in the clinical trials was oral candidiasis. So patients need to be told after they use this, you need to rinse your mouth out, spit the water out. We encourage them not to swallow it because what we don't want to do is see pharyngeal candidiasis as a result of using an inhaled steroid. It's also a DPI, a dry powdered inhaler. And you all know that there is emerging information in the literature about paradoxical bronchospasms. People take 1 puff of the DPIs and start to wheeze and cough. Should that occur, they need to be advised not to use this medication again and go to a different form of an inhaler. So both GINA, the Global Initiative for the Treatment of Patients with Asthma, as well as the EPR, the Expert Panel Report, also known as the National Asthma Education Program, now recommend the use of an ICS whenever a SABA is needed. And so this is going to be the first inhaler that is going to provide this in 1 copay. This has been in development for well over 10 years. And it was a difficult task to find a way to put both of these into 1 inhaler and into 1 chemical entity, but they figured it out. So what's the advantage? The advantage is it's a single copay. And they only have to carry 1 inhaler. And if any of you work with young adults, if it doesn't fit in their tiny little purse or it doesn't fit in their back pocket, they often are not going to, carry these inhalers. So I think the good news is it's 1 copay. The bad news is it's branded and it's about $400 to $500, says drugs.com for 1 inhaler. So with that said, it carries all the same warnings that the oral formulation of albuterol and the oral formulation of budesonide carry. But it's an inhaled steroid. So we do not see the same degree of systemic absorption that we see from the oral versions. But every drug that comes to market per the FDA will carry the same interactions, the same warnings as the oral formulation of the drug. So budesonide is a CYP3A4 substrate, uses that 3A4 isoenzyme for its absorption. So strong inhibitors that are used in a prolonged period of time, erythromycin, chlorithro, ketoconazole, itraconazole, those drugs can increase systemic exposure to budesonide. Again, it's not approved for kids. Now, on your slide, it says it will be available late 2023. I just received samples of this inhaler in my clinic. So it is now out. It is now available, and they are sampling it. But if you also want to send your patients to Airsupra, is its brand name.com, they can get a copay card for $0 for the first inhaler and $25 for the second one. And for many people, what we're seeing, because we've been using this now for about a month in our clinic, is that people are telling me that they used to have to use their albuterol every day before they ran. And what they're finding is after a couple of weeks, they don't need it anymore, that they'll use it once or twice a week, but not needing to use it every day. And it's probably because of the inhaled corticosteroid reducing that airway inflammation, and there's not as much of a need for the albuterol. So the canister also has a dosing counter on it. Many of you may remember the days we used to take apart the albuterol. We used to put it in a glass of water and look and see if it floated. That's how we knew if the medicine was empty, if the canister was empty. These newer inhalers have a dosing counter and it counts down. So our patients are going to know how many inhalations are left. And last but not least, it says here that the cost has not been announced. That I sent these slides in a month ago or so. The cost is now out between $400 and $500 for one inhaler if you wanted to pay cash for it. What questions can I answer for you on this inhaler? Let's go to endocrine. It seems to me like every week there's a new drug on the market to treat diabetes and in the world of endocrine. So let's talk about the drug called bexigliflozin. It is the newest SGLT2I to hit the US market. It's sold as Brenzavvy. It belongs to the class of drug called the SGLT2, the sodium glucose cotransporter drug. So basically, one of the defects of type 2 diabetes is that the kidneys inappropriately reabsorb glucose. So the way this class works is it makes people pee out about 70 grams of glucose a day. By the way, that's equivalent to about 2 Milky Way bars. They also, when they pee out glucose, they also pee out fluid. They often pee out calories, 300 calories a day. So what we often see in patients on this class is one, weight reduction. People do lose weight on this class because of the offloading of glucose and the offloading of calories. But what we also see with this class is a lowering of blood pressure. Often between 3 and 5 millimeters is what you can expect when we add an SGLT2 on. Not a real robust reduction, but many of the drugs in this class, EMPA and dapagliflozin, now have indications that extend beyond diabetes. In fact, both of those drugs have indications for people with kidney disease who don't even have diabetes to have these drugs added on to reduce the risk of end-stage kidney disease. They're also being used a lot in the world of cardiology because they've now shown benefit in congestive heart failure, reductions, as well as hospitalizations and death. We've also seen reductions in MIs and strokes as well with this class. So there's a lot of benefit that exists in this class. But because this drug is so new, its only indication that it's coming to market with is type 2 diabetes at this time. There are ongoing studies to look at what does this drug do in the world of major adverse cardiovascular events, or what we call MACE events. And what they saw in the clinical trials was, while they don't formally have an FDA indication for any MACE events at this time, in the clinical trials, patients who were given this drug, there were about 7.9% who received bexigliflozin who had a major adverse cardiovascular event. It was at 10% in the placebo group. So the good news is, even in the original clinical trials, we're already beginning to see that differentiation in people who get treated with placebo versus this drug. And the good news is it was very favorable for the drug. Now, the dosage is 20 milligrams dosed once a day. It is one and done. This is the dose that is available. I encourage my patients to take this first thing in the morning because the way it works is it does offload fluid. So they tend to have a lot increase in their urination. so I don't want them up all night. So I tell them to take it in the morning. This drug should not be started when the GFR is below 30. Although we are now seeing nephrology using EMPA and dapagliflozin down to GFRs, they're starting them down to GFRs of 20, and they're now even continuing them on all the way to dialysis because of the benefit that these drugs have in renal protection. You may remember when these drugs first came out, we didn't start them in anyone with GFRs under 60. And now the safety data are accumulating that we can start EMPA, for instance, Jardiance, all the way down to a GFR of 20 and continue them on to dialysis. So I suspect over time, what you're going to see is that we will start moving that needle down with this drug as well. But as of now, if GFR is under 30, we do not start this medication. I will tell you that I think that if I were to look at this medication and compare it to EMPA, DAPA, and canagliflozin, it's probably a weaker SGLT2I, at least from an A1C perspective. Because usually when I add these drugs, I get a 0.8 or so, 0.8 to 1% A1C reduction. You can see that in the 2 trials that were done for Bexa, it lowered A1C around 0.5%. Remember, every 1% A1C reduction correlates to about 35 milligrams per deciliter of glucose, right? So if it lowers A1C 0.5%, we're talking it's lowering the average glucose somewhere around 18 milligrams per deciliter. Not real robust, but 31% of patients who were started on this medicine were able to get to an A1C of under 7%, which is our goal for most of our patients. Some of our patients we want to run under 6.5%, some we want to run under 8%, but most people we're trying to get below that 7% mark. In terms of adverse events, it's exactly what we see with this class. It's increased urination. It's vaginal candidiasis, because when you offload glucose and you put it around the vagina, you're going to increase the risk of candidiasis. And it's also UTIs and pyelonephritis, because glucose in the urine makes the urine more alkaline and they're more likely to develop a UTI. So these are the side effects that we see, a little bit increase in thirst, but they're not really significant. Now, what are some precautions? This class, this drug carries all the same warnings as the SGLT2s. The pyelonephritis, the UTIs, the candidiasis, and Fournier's gangrene. Fournier's gangrene is necrotizing fasciitis of the perineum. And I don't know if you've ever seen it. I've seen it once and hope to never see it again. I saw in a woman post-episiotomy who developed Fournier's gangrene. It's necrotizing flesh-eating bacteria of her vagina. It is not pretty. There's a lot of disfigurement and people can die from it. There have been about 12 cases of this reported to the FDA in patients on SGLT2Is. We don't know why. We don't know what the mechanism is for it, but you want to know that that risk does exist. There is also a warning in the package insert with all of these products regarding lower extremity amputations. This originally came out with canagliflozin, which is Invokana. The FDA has issued a statement that they are not seeing significant increases in anyone on SGLT2Is, but that warning continues to remain in the package insert, and we don't know why. We don't use this in pregnancy, nor do we use it in lactation. And there is a recommendation, which a lot of primary cares are not doing, is that SGLT2Is, because of their impact on electrolytes and fluid, probably should be discontinued 3 days before any surgical procedure. And a lot of primary cares are not aware of that, and they're not doing that. So in case you ever end up on Jeopardy and they ask you the question, what is the first SGLT2I that will be approved for use in cats with diabetes? It's bexigliflozin. So there's your Jeopardy answer. What's interesting about this drug is it's only being sold through Mark Cuban's pharmacy. Any of you familiar with Mark Cuban's pharmacy? It's called Cost Plus. Cost Plus is a pharmacy that Mark Cuban, he owns the Dallas Mavericks. Is that what he owns? He's also on Shark Tank or something like that. In any event, he has a pharmacy. If you have not looked at this website, I would encourage all of you to go to the website and look at the drugs that are available. Have you ever tried, or pharmacists, what's the cost of Estrace vaginal cream in your pharmacy? What are patients paying for it? Premarin vaginal cream for a month, 100, 150, depending upon the pharmacy. It's being sold in his pharmacy for $22. So Bexigliflozin is available only in his pharmacy for $47. Now, to put that into compare it to EMPA, DAPA, those drugs are $1,000 a month if you paid cash. So to make this available and to give a patient who's uninsured, has social determinants of health, an opportunity to be on a brand new SGLT2I for $47, I have loaded the pharmacy into my EHR. I send in 90-day prescriptions to the pharmacy and they ship it to the patient. And a lot of the branded drugs out there are available in the pharmacy. He's cut out some of the middlemen to try to help our patients to get access to this drug. By the way, he's now partnering with some of the big supermarket chains, particularly in Florida, where people are on Medicare Part D. Some of them are getting into the donut hole. He's making this available at some of the pharmacies as well in these supermarket chains. But no significant drug-to-drug interactions. And I think it's a good option, maybe not as robust, maybe not as much outcome data as some of the other SGLT2s, but for people who can't afford the others, I think it's a good option. Questions for me on Bexigliflozin? All right. If you have not heard about this drug, not sure where you've been in the last year, but the phone has been ringing off the hook on tirzepatide. People want this drug. So it's come to market. It's been around now about a year. It's a dual agonist. It's a GLP-GIP agonist. So when you and I eat our breakfast this morning, when we ate our breakfast, it triggers the release of two important incretins, GIP and GLP. Those two incretins go out to the alpha and beta cells of the pancreas and say, hey, blood sugar's rising. You need to drive up insulin to handle that first phase insulin secretion or those blood sugars that are rising, and you need to drop glucagon. That's how the incretins work. People with diabetes tend to have diminished levels of incretins. And so what this drug is doing is it's enhancing what they already have. It's an agonist. It's going to make them have more incretins. What's different about tirzepatide compared to a drug like liraglutide, semaglutide, dulaglutide, those are drugs like Trulicity, Victoza, and Ozempic, is that this is a dual agonist. It's both GIP and GLP, whereas the drug liraglutide, for instance, is only a GLP-1 agonist. So you get two incretin impacts. But maybe its best effect is that it delays gastric emptying. So it makes people feel full with smaller amounts of food. And people with diabetes and people living with obesity tend to consume more food in order to be satiated. And they will tell you, it takes a lot of food for me to feel full. And that's because of their diminished incretin levels. So by delaying gastric emptying, they feel full with smaller amounts of food, they don't eat as much, and they tend to lose weight on this class. And of all of them, if you look at the ADA guidelines, this is the drug that people, if they were to rank every drug on the market for diabetes, this is the one that people lose the most weight on. Stay tuned. In the next couple of years, you're going to see a triple incretin agonist. And there are multiple drugs that are in development right now to not only bring down blood sugar, but also to reduce weight in patients with type 2 diabetes. So one of the things I tell my patients before I start this drug is, one, you need to take the amount of food that you normally ingest and you need to cut it in half. Because if you continue to eat the quantity to which you've become accustomed, you're going to throw your food up. Or it's going to sit there. Some of you may have been hearing recently about all these folks that are ending up in the emergency department because they've been started on a GLP-1 GIP drug, and they're ending up with vomiting. They're ending up with this intractable vomiting, and they're going to the emergency room because what is happening is these people have often had diabetes for years. They've often had some underlying gastroparesis that we didn't know about, because how do they know unless they're throwing up or they're nauseated? We often don't know unless we do a scan, for instance, a gastric emptying study, and they go on these drugs and it delays their emptying so much that they are just vomiting it's intractable vomiting. So one of the things I tell people is, as we go to write these meds, we've really got to be questioning about gastroparesis. And do you ever feel like that food sits there? If so, we have to be really cautious with this medication. As of 1 week ago, it is now indicated not only for type 2 diabetes, but is now indicated for obesity as well. And obesity in the clinical trials is defined as a BMI of 27 or greater with any other obesity-related comorbidity, i.e. hypertension, hyperlipidemia, diabetes, or a BMI of 30 or greater. It is not sold as Mounjaro for obesity. It's sold as Zep, Z-E-P, B-O-U-N-D. So you pharmacists who have thought you've been busy with Wegovy, buckle up, because people are going to want you to work on prior auths and to get Zepbound approved, because it truly is the drug associated with most weight reduction. It is not, none of these drugs are approved for type 1 diabetes, although there are clinical trials underway. So how do we prescribe this drug? It is an increase in the dosing once a month. So it's a once weekly injection. We start at 2.5 milligrams. We have them inject once a week, and they do that for 4 weeks, and then we move them up to the 5 milligrams. And we do that for a month, and then we move them up to the 7.5 milligrams. Our goal is to get them to 15 milligrams. Here's why. The lower dosages of the 5 milligrams is as effective in A1C reduction as the 15 milligrams is. So if you look at clinical trials, A1C reduction with the 5 milligrams is 1.7 to 1.8% reduction. In the 15, it's the same. But the reason we want to get people to that 15 milligram dose is that's the dose associated with most weight reduction. So while A1C numbers are pretty similar regardless of dose, weight reduction is not. The higher the dose, the more efficacious it is in terms of weight reduction. So when we look at the clinical trials, they studied 1,500 patients they did 5 clinical trials to get this drug approved. They were called SURPASS 1 through 5. In one of the clinical trials, about 30% of the patients were 65 and older, and about 4% were 75 and older, and there is no dose alteration for people 65 and up. So the good news is we have pretty robust data on older adults, which we often don't have when drugs come to market. So to give you a sense of what you can expect with this medication, I pulled SURPASS 1, just one snippet. The package insert for this drug is huge, but I pulled SURPASS 1. It's a 40-week monotherapy trial. The average patient had A1Cs in the vicinity of about 8% entering the clinical trials. That's pretty normal, by the way. Most diabetes studies, their A1Cs are around 8% at baseline. And then they followed them at 40 weeks, 5, 10, and 15 milligram dosages. And if you look at the A1C reduction in the placebo arm, it was 0.1%. And the tirzepatide 5 milligrams, it was 1.8. And then 10 and 15 milligrams were 1.7% reductions. So we're talking somewhere in the vicinity of about 70 milligrams per deciliter reduction in glucose, or 2 A1C points that are clearly going to take these people under 7%, which are our goals. Now, what about weight reduction? With the placebo arm, keep in mind that all diabetes clinical trials, they're educated on diet and exercise as part of every arm, so lifestyle. You can see that 1 kilo in the placebo arm, but the higher we push the dose, the greater the weight reduction. And I have a number of colleagues that are using this class of medication in psychiatry, who are using this to help patients who are on the antipsychotics, the antidepressants that are causing such profound weight gain and such metabolic adverse events that a lot of my NP colleagues are actually pairing the use of the GLP-1s, GIP drugs in psychiatry to enable these patients to be able to continue on their meds and get weight regulation on those medicines, which is great. Because I said this yesterday, and you know this yourself, that the weight gain that people develop and the adverse metabolic effects from the second generation antipsychotics really play a role in increasing the risk of diabetes. So you can see about an 8 kilo weight drop. So that's somewhere in the vicinity of what, 17, 18 pound reduction over a 40-week trial. Now, there were some people in the Zepbound trial. In fact, it was in the vicinity of 40% of patients in the tirzepatide for obesity trial that lost 20% or more of their body weight. And it was somewhere between 30 and 50% lost 20% or more of their body weight. That's unheard of. If any of you have been following the obesity drugs, we've been thrilled over the last decade to see a 5% or 10% drop. And these drugs are now causing 15 and 20% and sometimes more weight loss. So the good news is with tirzepatide, there is no renal or liver enzyme, no renal or hepatic dosing adjustments that need to be made. So many of our patients with diabetes have underlying kidney disease. So the fact that we don't have to pull this away in the setting of kidney disease is reassuring. Our biggest concern is the gastroparesis. Our other big concern is pancreatitis. These meds carry a pancreatitis warning. You want to be cautious if they've had pancreatitis in the past and in terms of using them. But if they develop pancreatitis-like symptoms on these meds, the drugs need to be pulled away. These are not approved to be used in pregnancy, nor are we using them in children at this time. You also need to recognize that these drugs can alter, because they delay gastric emptying, the absorption of drugs that have a narrow therapeutic index. So any drug that we're monitoring levels on, drugs like lithium, drugs like warfarin, it's important that we get patients their levels rechecked. I usually do them within a week of starting these meds, just to ensure that those INRs are not going through the roof and that these people are not at an increased risk for bleed. The two contraindications are a history of medullary thyroid carcinoma. By the way, medullary thyroid carcinoma is less than 1% of all thyroid cancers. It is a very rare form of thyroid cancer. Most thyroid cancers we see are follicular, not medullary. So just because they've had thyroid cancer, if it's follicular, it is not a contraindication to this medication. And then I don't know if any of you have a patient in your clinic with multiple endocrine neoplasia syndrome. If you do, this medication class is contraindicated as well. It is a very rare condition that we just don't see, either a personal or family history of such. Those are your contraindications. So what about adverse events? Clearly, it's GI related. It's nausea, diarrhea, constipation, vomiting, and decreased appetite. The higher we push the dose, the higher you see these adverse events. And in my EHR system, I have this little button that when I go to prescribe a medicine, in this little box at the bottom, it pulls up the cost of the med, and it gives me a little happy face. If it's covered on their formulary, it gives me a red sad face if it isn't. What I find is for most of the patients, I'm getting a red unhappy face. And this $1,000 is not what I'm seeing. I'm seeing about $1,400 for patients. Now, up until last week, I would say to patients, because patients would come in and say, can you please prescribe this drug, Mounjaro, for me for weight loss? I say no, I won't prescribe it because A, it's not approved, and B, your insurance is not going to cover it because they're expensive meds. Is there anyone here from North Carolina? North Carolina government just announced that for the employees of the state who have state insurance, they will no longer cover any of these obesity drugs for their constituents. They have said that it is costing the state $6 billion a year, and as such, they're not going to cover them. So what they're now going to do is they're going to cover their diabetes drugs, right? It's just insane to me. We probably wouldn't need a new diabetes drug on the market if we could help people with their diet, their exercise, and their weight loss. But that's just my own opinion, for whatever my own opinion is worth. But these drugs are expensive. And again, now this drug is fully FDA approved for obesity. And while I'm here, let me take a moment to talk about Wegovy. Wegovy is semaglutide. So it's like Ozempic, but at a higher dose, 2.4 milligrams once a week for obesity. The company has announced that semaglutide, Wegovy, will not be available until at least the first quarter of 2024 at the starting dosages. So one of the things we're seeing around the nation is that the starting dosages of semaglutide, Wegovy, are not available for patients. They continue to manufacture the 1.7 and the 2.4 dosages. So if your patients are already on them, we're able to continue them on because they are putting their efforts into maintaining those doses so that people who are already on the drug can continue. What they're also doing is taking the semaglutide and they are pushing the manufacturers, the manufacturing chain, to make Ozempic. What they're trying to do is keep enough semaglutide in the pipeline so people with diabetes can be treated with the drug and really prioritize diabetes over obesity at this time. So that's what's going on with Wegovy. So I don't even try these days to write Wegovy because you can't get it anywhere. So what are patients doing? They're going to spas. They're going to spas and they're paying $300 and $400 a month to have these drugs compounded in compounding pharmacies, and they are being shipped to the patient, and the patients are paying these providers cash for these meds. The problem is that for many of these pharmacies, these products are coming from places that there is less regulation. And so people have no idea what they're injecting into the body. They're changing the compound just enough to avoid patent infringement, but many of the attorney generals in states around the nation have announced that they are going to be starting to target these compounding locations. In fact, a friend of mine runs a spa that sells these meds, and the place she has been buying from in Florida is now no longer accepting any phone calls, no longer manufacturing or compounding at all. They have been shut down by the attorney general in Florida. So questions for me on these two, or the obesity and diabetes meds? Let's go to Tzield. I'm not going to spend a ton of time on this because this is not something that many of us are going to do in primary care. But I will tell you, we are getting very close to being able to prevent kids from developing type 1 diabetes. And some of you may have seen that there was a study published where a child actually wore an external pancreas for 7 days and functioned on that external pancreas. So what is Tzield? It's a monoclonal antibody. You can tell it ends in MAB. We don't know its actual mechanism of action, but what we believe it does is we believe it deactivates pancreatic beta cells, or pancreatic beta cell antibodies, basically. When we begin to make antibodies against the pancreas, which is what type 1 diabetes is, it's an autoimmune condition, we know that those antibodies often begin to be produced years before the child ever develops type 1. And I pulled up some information this morning that I wanted to just share with you about this product, because what's happening is around the nation, parents are enrolling their kids in these pre-diabetes type 1 trials, because we know that once the child begins to produce antibodies against the beta cells, that it's not a matter of if they're going to develop type 1, it's really just a matter of when. So when there is a family history, for instance, of type 1, when the child has 2 or more autoantibodies, this is called stage 1, but has no symptoms, their lifetime risk of progressing into stage 3, which is type 1 diabetes, is 100%. So once they've developed 2 autoantibodies, even if they're asymptomatic, over the course of their lifetime, 100% of these kids are going to go on to develop type 1 diabetes. If we can pick these kids up early, introduce them to a product like this, and there will be more and more of these products coming onto the market that are going to deactivate those autoantibodies, we can delay their progression on to the next stage. Stage 2, by the way, is when they're still asymptomatic, but they're producing more and more autoantibodies. Stage 3 is when they develop hyperglycemia, and usually these kids present in type 1 DKA. But listen to this statistic. If they're in stage 1, 2 autoantibodies, their 5-year risk of type 1 is 44%, their 10-year risk is 70%, and their lifetime risk is 100%. When they get to stage 2, their 5-year risk is now 75%, and their 10-year risk is now 100%. So that is what this product is working on, is to deactivate those autoantibodies. And by doing that, we can delay their progression onto diabetes. So it's an IV drug. It is infused over the course of 30 minutes minimum, and it's done for 14 days only. And they're going to be pre-medicated because anaphylaxis is an adverse event reported out in the clinical trial. So there's this whole protocol of antipyretics as well as antihistamines and even antiemetics that are given. So they're going to have 2 autoantibodies that have been identified with blood testing. And then they also will be asymptomatic, and they will be given this medication. There's CBC monitoring, there's liver monitoring, and the key for primary care is we want to make sure that their vaccinations are all up to date. As many of them as we can get them up to date on, because this is immunosuppressing while they're receiving it. We're going to monitor liver enzymes, and there's this whole protocol for when it needs to be discontinued. And we're going to monitor for serious infection and acute hypersensitivity reactions. So at the end of the day, it is the bottom line that I wanted you to see. And that is the median time from randomization in the trial to stage 3. Remember, that's someone who's now symptomatic with type 1 diabetes, is 50 months in the teplizumab group. It's 25 months in the placebo group. So it gave these kids 2 additional years before they developed type 1. And so stay tuned. I think there's going to be a lot more products out there like this. But I know for me that we have a couple of children who are getting this infusion at Joslin in Boston, because they are one of the leading centers in the research of these products. Questions on teplizumab? All right, let's go to some quick, we'll reset and come back and talk about long COVID and what we know about it. So some quick updates. Andy, I keep getting an announcement here that the internet is unstable. So if you can just keep watching that, that would be great. I don't want people at home not to be able to see and to be able to sign in. Okay. So have you all heard that the FDA approved the first birth control pill to go over the counter to be purchased in the pharmacy without a prescription? It's a levonorgestrel product, and it will be sold as Opill. This product has been available in Europe for over a decade, and the FDA voted 100% in favor of this RX to OTC switch. We'll bring that back up. And here comes my microphone, I think. Can you all hear me okay? All right. So it's a progestin-only pill. And because it's a progestin-only pill, we don't have to worry about DVTs. We don't have to worry about young women using this who have a history of breast cancer or who are at risk for clots, pulmonary emboli as such. It was officially approved this summer. The company has now announced that it will be available in the first quarter in your pharmacies of 2024. We are unsure as to what the cost is going to be. I have not been able to find any projected cost out there, but many people are saying it will probably be somewhere between $25 and $45 a month. Certainly going to be more than what people are paying for progestin-only pills when we prescribe them, because a lot of people are paying $4 a month for those pills. But what it's going to do is it's going to make oral contraceptive available to folks who may not have access to a primary care, women's health provider, etc. Questions on Opill? Do you have this in your pharmacies yet? Naloxone, over the counter, without a prescription. It's being sold in a 2-canister package. In the vicinity, I've seen it in my pharmacies for in the $40 range for two nasal sprays. It is a 4-milligram nasal spray, and it is approved again for that OTC switch. It is approved for both children, or all three, children, adolescents, and adults. What I am telling my patients, particularly those who are using injection drug use, who have injection drug use, buying products off of the street, etc., is that if they have someone in their family who's doing that, you want to encourage them to buy at least 2 to 4 of these products and have them available. The reason is that the synthetic fentanyl that is being introduced into a lot of these drugs that people are buying off the street, the synthetic fentanyl is associated with rigid chest wall syndrome. And if any of you've worked in an ER and seen us have to give this, we've had to give 4 and 5 doses of Narcan to reverse the rigid chest wall syndrome and the respiratory depression that we're seeing with the synthetic fentanyl. Just remember, synthetic fentanyl, the grain, it's the size of a grain of salt, is the size that is fatal in our patients. And it's being introduced into a lot of these drugs. So I tell people, have multiple doses available if there is injection drug use. People are buying it off the street. If they're on opioids and you want them to have naloxone available at home and they're using prescription opioids, that's a different story. A couple of doses will be fine, but injection drug use, different story. The drug called linaclotide has been around now for over 7 or 8 years. It's sold as brand name Linzess. You've been using it with your patients for chronic idiopathic constipation. We've also been using it for IBS-C, irritable bowel syndrome, constipation predominant. So the way this drug works is it works on what are called guanylate cyclase C. It's a guanylate cyclase C agonist. It's going to add more water to the stool. It's going to speed up GI motility. It's going to reduce pain that's associated with IBS-C and chronic constipation. Up until recently, it was approved 18 years of age and older, but now it's approved down to 6 years of age for kids who have functional constipation. And these are kids who decide, I'm just not going to poop. I don't know if any of you have ever met them, but they are bound to determine they are done pooping. And it's often because they had a painful bowel movement and now it hurts to go and they're scared that that's going to happen again. We also run into these kids because they don't want to have to go poop at school. And they don't want to go into the bathroom, so they functionally hold. The longer they hold, the more their rectum distends. The more their rectum distends, the less sensitivity they have, and they start developing overflow. And they start having enuresis as well because the bowel bladder innervation is so closely connected. So one of the things we've done with these kids for years is use the drug called polyethylene glycol, Miralax. We've cleaned them out and then put them on a bowel regimen. We're doing the same thing. We're cleaning them out with polyethylene glycol, and now we're using linaclotide for those kids who may not have responded. So this is another option for functional holding in kids. It is not recommended in any child under the age of 6 years of age. And by the way, it's a 72 milligram dose. The FDA has now added a boxed warning on all ADHD products that state the following. Patients should never share their prescription stimulants with anyone. And the box warning will also describe the risks of misuse, abuse, addiction, and overdose risk associated with all ADHD meds in the class. So your amphetamine products, your methylphenidate products are all going to carry this warning. And we talked about this yesterday, so I don't feel like we have to spend any time on it, but you all know it's a disaster out there in the world of ADHD drugs. You've got brexpiprazole. Brexpiprazole is sold as Rexulti. I mentioned this yesterday. It's a second-generation antipsychotic, a newer agent, less adverse metabolic impact than older drugs, like, for instance, Zyprexa, clozapine, et cetera. But its newest indication is agitation associated with Alzheimer's dementia. And remember that those second-generation antipsychotics all carry warnings, boxed warnings, regarding using these meds in patients with psychosis related to dementia, that there may be an increased risk when compared to placebo of premature death. Those deaths were either infectious or cardiovascular in nature, and they were about 1.6 to 1.7 times placebo-treated patients. So that boxed warning still exists, but in the trial that was done with regard to agitation, there was no increased risk in death in patients that were treated with brexpiprazole. And so this is one of the drugs we're using in our patients with dementia. We've got semaglutide and Qsymia, phentermine topiramate. Both of those are now approved 12 years of age for adolescents with obesity. And the semaglutide is 12.4 milligram dose, so we can take these adolescents all the way up to the highest dose. Remember what I said to you? It's great that it's approved. We just can't get it right now. We need to wait a good 6 months or so before we expect the supply chain to be able to supply new prescriptions for this medication. Phentermine topiramate, just keep in mind, topiramate, we don't want anyone to get pregnant on topiramate. It's associated with cleft lip and cleft palate in the developing baby, also associated with kidney stones. And there is information that topiramate at 200 milligrams, not that you would get there with Qsymia, but 200 milligrams may reduce the efficacy of oral contraceptives. So we want to be careful with patients with these drugs, with this drug. Secnidazole, coming onto the market to compete with metronidazole, tindazole. This is a drug that is now approved for both trich as well as bacterial vaginosis. It is a 2-gram dose, single dose, and is approved now down to 12 years of age for adolescents with BV and or trich as a 2-gram single dose. The drug called azolastine, you know of that as Astepro, is a nasal spray for allergic rhinitis. It is now sold over the counter without a prescription, 6 and older. So it's basically like shooting Benadryl into the nose. It does have up to a 40% sedation if people snuff it in. So if people are asking you about this, I tell them keep their nose over their toes, don't snuff this in, because the sedation rates can be as high as 40%. It's Astelin, Astepro, azolastine is its generic name. We've got Trelegy. Trelegy is a triple drug inhaler. It is an ICS with a LABA and a LAMA. It is now approved. When it first came on the market, it was approved for COPD. It's now approved for asthma. The problem is with this product is that in both asthma guidelines, vilanterol, which is the LABA component, is not the preferred LABA that is now recommended to be used by both of the guidelines. Formoterol is the preferred LABA because in every country in the world, formoterol, you know of that as Foradil, is a rapid acting inhaler, but it's also a LABA as well. In the US, its only approval is long-acting beta-2, but both of the guidelines are now recommending formoterol as the LABA that should be used in all patients with asthma. So we're not seeing a lot of use of Trelegy in asthma for that reason. And remember what the asthma guidelines say. You never introduce a LAMA, a long-acting muscarinic, in patients with asthma unless they're already on a LABA ICS and are not well controlled. This is kind of our last step before they go on to needing the biologics. We talked yesterday about Qutenza, the capsaicin 8% patch. We applied this in the clinic, indicated for postherpetic neuralgia, but its newest indication, it's like a little boot we put on their feet. They keep it on their foot for an hour, blocks pain, reduces pain by up to 30% for 12 weeks. It's about $1,000 an application. This is something we're doing in the clinic, particularly for people who have significant diabetic neuropathy. And levonorgestrel. I joke about this with my patients because every year I see them, I say, here's the good news. The good news is someday we're going to be able to put levonorgestrel Mirena into your uterus at menarche, and we're going to not need to take that sucker out until you get to menopause. We're going to need a crowbar to get it out when we finally get, I'm joking, we don't really need a crowbar, but it is now approved for 8 years as a contraceptive option. Some of you may remember when it was first FDA approved, it was 3 years. We are now up to 8 years. So a lot of the women that I see really love this as an option because many of them become amenorrheic. And for my perimenopausal women, it buys them 8 years of not having to worry about a contraceptive option. And it's progesterone only. So you're not seeing that increased risk of DVT, cancer, breast cancer, et cetera, risk. We've also, some of you may remember that there was an injection, it's like an immunization, but it was an injection called Evusheld, and it became available at the very beginning of the COVID pandemic. And we were giving it to people who were severely immunocompromised every 6 months to prevent them from getting severe COVID infection or hospitalization or death. This has now been EUA removed, so it's no longer available on the US market because it does not work against Omicron and the Omicron subvariants, which is basically what we are dealing with now. It lost its efficacy, like many of the monoclonal antibodies did. If you remember at the beginning of COVID, we were giving lots of monoclonal antibodies. All of them have not been shown to be effective against Omicron. Now, many of you have seen patients over the years and have given them injections of erythropoietin or EPO, right? You've used Aranesp, Procrit, and we give those products to people with kidney disease who have an anemia related to decreased erythropoietin. 90% of erythropoietin is produced and housed in the kidney. So people who have chronic kidney disease often have declining amounts of erythropoietin. By the way, we see decreasing amounts of erythropoietin when the GFR drops below 49. That will be a clue to you that you're probably going to see a normocytic, normochromic anemia related to chronic kidney disease. So for years, we've given these folks injections of Procrit. Now there's a pill available. And it is a pill, daprodustat, and it is a pill that these folks take for anemia related to chronic kidney disease, and it's given in patients on dialysis. It still carries all the same warnings as the exogenous EPO, but the way this HIF-PHI drug works is it enhances erythropoietin production. So it basically, instead of giving them exogenous EPO, you're triggering their kidneys to produce their own endogenous erythropoietin. So there's always the concern with this product about coagulopathy. There's also the concern about taking people's hemoglobin and CRIT too high, just like in the world of EPO as well. We want to maintain their hemoglobin under 12 and for many people, we keep it somewhere between 8 and 10. The higher we push the hemoglobin, the greater the risk of MIs, strokes, and clots. Remdesivir, approved for end-stage kidney disease, including dialysis. And as I said to you yesterday, fully FDA approved. When we talked about depression and anxiety yesterday, we talked about the drug called Zurzuvae, and it is zuranolone. It is a drug that we are waiting to be DEA assigned. So it's been FDA approved, but we're waiting on a schedule. We're waiting on the DEA to assign a schedule. We think it's going to be a Schedule 4 based on what we are hearing. And it is what is known as a positive allosteric modulator. It is 1 pill a day at bedtime with a high-fat meal for 14 days. To reduce, we began in the clinical trials, they began to see benefit with this product at day 3. And again, this is for women with postpartum depression and can be started anytime after that pregnancy or after delivery, and can also be used in women who are breastfeeding. So stay tuned for that. So now let me wrap this all up with some vaccine information. And let's talk about RSV. We're going to talk about this in the emerging infectious disease lecture as well, but I just want to talk specifically about the vaccines. So the first vaccine to be FDA approved is a vaccine called Arexvy. It's an RSV, respiratory syncytial virus. It's an adjuvanted vaccine. The adjuvant that is used in this vaccine is the same adjuvant that is used in the shingles vaccine. So you're going to see when I show you injection site pain that it looks very similar to the adverse events that we see with the Shingrix vaccine as well. This vaccine has only one indication, and it is approved for people 60 and older who are at risk for RSV. RSV is now one of the top 10 causes of community-acquired pneumonia in the United States, and in people 60 and older is associated with 14,000 deaths every year as a result of lower respiratory tract disease. So I'll go through all of the pathophysiology when we talk about infectious disease. But to get this vaccine approved, they studied 25,000 patients, and they looked at the efficacy of this vaccine in terms of lower respiratory tract disease caused by RSV in people 60 and older. And you can see that the overall efficacy was around 82%. But then what they also looked at was efficacy, lower respiratory tract disease, but in people with at least one comorbidity, and the efficacy went up to about 94%. And in people with two or more lower respiratory tract infections, two or more comorbidities, we saw a relatively similar efficacy. So the efficacy against severe disease, hospitalization, or death is at 94%. What we do not know is how long it's going to last for. There is evidence out there that it's probably lasting at least 2 years, but what we need is additional continued studies to see how long this benefit is going to last. So when your patients say, how often am I going to need this? My answer is, I don't know. Worst case scenario, every year, but I don't think so. I think it's going to be at least every 2 years or more. And by 2025, we expect that RSV, COVID, and flu will be able to be had in the same vaccine. And we expect that by 2025. You will be unable to move your arm for decades after that vaccine. I'm kidding, but not really. But in any event, we expect by 2025 that triple combination will be available. And some people are predicting that next year, flu season, COVID and flu will be available in the messenger RNA vaccines in the same vaccine if people want it. So it needs to be reconstituted. It's a 0.5 ml given in the deltoid. And the biggest caution is syncope. And that's with every vaccine. But look at the injection site pain, 60%. There was fatigue, 33%. Those are numbers that we see that are very similar to what we see with the shingles vaccine. So as I said to you yesterday, we'll do this in the immunization section. I'll cover how we build this out, but it's part D, which is why all of you that are working in pharmacies are getting so many people now who are on Medicare coming in and asking you for it. Those of you who are in primary care, 60 to 64, when they're not on Medicare, get this on board. so that you don't have to worry about Medicare Part D. What happened with this vaccine is GlaxoSmithKline is the manufacturer. They began the studies of using this vaccine in pregnant women. In their clinical trials, there was a higher rate of preterm labor in women who were given this vaccine. So they abandoned the clinical trials, and their only indication for this vaccine is 60 and older. The FDA has asked them to continue to monitor two things that were seen in the trials. Guillain-Barré. If you've been following what's going on with the shingles vaccine now has a warning on Guillain-Barré. It's now part of the labeling. There were 2 cases, I believe it was 2, in the clinical trials of Guillain-Barré after getting this vaccine, and there were slightly higher rates of AFib in patients within 6 months of getting the vaccine. But in the 6 months to 12 months after the vaccine, there were higher rates of AFib in the placebo arm than there were the vaccine arm. So was it just a number thing that happened that way? Was there a link with the vaccine and AFib? Stay tuned. The FDA is requiring mandated monitoring. And what studies are underway? 50 to 59-year-olds. So if people are asking you, there are studies underway for younger individuals, particularly those at risk to get it. And the other thing that I think is really important is that the only vaccine that this was studied co-administered with is influenza. So when patients come into me and say, I need my flu, my COVID, and my RSV, just because you can doesn't mean you should. What I mean by that is I say to patients, I am not giving you all 3 at once. I don't have safety information. And while the CDC says, if you want to do it that way, you can, I'm telling them for now, I'm separating the RSV. I'll give you RSV with flu, 1 in each arm, but I'm not giving you all 3. So a lot of my patients are now getting flu and COVID together. I wait 2 to 4 weeks and I put them on for an MA visit to get the RSV. That's what I'm doing. Again, it's not right or wrong. It's just I want additional studies on this before I start giving 3 vaccines all at one time in this population. So then what happened was Pfizer, and by the way, it would have been nice if they named their vaccines a little bit differently. They're both named A, and so my fear is that there's going to be mistakes that are made. Glaxo's is Arexvy, and if you look at the box of it, it looks just like the shingles box. It's the same color. And I'm so color focused. When I pull vaccines out of the closet, I'm scared mistakes are going to be made. But in any event, this is called Abrysvo. And Abrysvo has 2 indications, 60 and older and pregnant women. So this is the only one that we should be giving to pregnant women. This is not an adjuvanted vaccine, which is why when you see the adverse events, you're going to see that they're lower than what we saw with the Arexvy. And I think it's because of the adjuvant. So they studied the same thing, respiratory infections related to RSV, lower respiratory tract, 2 or more symptoms, 3 or more symptoms. Their efficacy is between 66 and 85%. I am not here to tell you that one vaccine is better than the other. But if you look solely at numbers, efficacy 66 to 88 versus 80 to 90, is there a difference in efficacy? I don't know. No head-to-head trials. But if you look at adverse events, 10% have injection site pain. That's a heck of a lot less than 60%. And I think it's probably because of the adjuvant. So this is also paid for under Part D. This is also monitoring for Guillain-Barré. And for now, it's one and done, and it was studied with flu vaccine. But what's different from Arexvy is that Abrysvo is the first vaccine. Let me skip this slide. I'll come right back, I promise. Abrysvo is the first RSV vaccine to be approved, or the first vaccine actually to be approved for what we call maternal transplacental antibody transfer. Maternal transplacental antibody transfer, meaning it's the same thing you're doing with a Tdap. We're giving Tdaps to women in pregnancy in the second and third trimester. So she makes active immunity, gives it to her baby in utero, and her baby's born with 6 months of antibodies against pertussis. By the way, we've been doing that since 2013. Does anyone know what percent of pertussis hospitalizations and death have been declined with that? 70% reduction in infant hospitalizations and death related to whooping cough or pertussis by giving moms the Tdap vaccine with every pregnancy. Pretty amazing. So this is approved to be given to moms so that she makes antibodies. She gives them to her baby so that her baby in the first 6 months is not born or doesn't get RSV. Or if they do, it's less severe. So I have to give you I have to take a few seconds to explain this. If you look at the package insert, the package insert for Abrysvo says it was studied 24 weeks of gestation through 36.7 or 36.6, just before the 37th week. When they looked at administration of this vaccine between 24 and 32 weeks, there was a higher rate of preterm labor. So what the FDA did was they said, while the studies included 24 to 32 weeks, we are taking that off the table. That this vaccine should only be given 32 to 36.6, because when it's given before 32 weeks, the risk of preterm labor goes up. And so by moving it to 32 to 36.6, there's actually higher preterm labor in the placebo group than there was in the study group. How efficacious was it? 81% reduction. So efficacy, 81.8% against severe cases of RSV in the first 90 days of life, and then 69% in the first 6 months of life. If a mom gets Abrysvo, her baby does not need nirsevimab, as long as the vaccine was given to mom 2 weeks before the baby was born. We need those 2 weeks on board so that she can make antibodies so that her baby has protection. So let me bring you back to nirsevimab. Let me go backwards here. This is the one that's been pretty controversial in that it's not a vaccine. It's a monoclonal antibody. It's now universally recommended for all babies in their first RSV season, in the first 8 months of their life. And for babies born with heart and lung disease, they want this to be given in the second RSV season as well. The problem is 18 states in the nation have universal access to vaccines. My state is one of them. What that means is every insurer in my state gives the state money to purchase vaccines through the CDC. But our state statute says that money can only be used for vaccines. Well, this isn't a vaccine. It's a monoclonal antibody. So in my state, we are unable to get this vaccine unless we private purchase it and then bill it out to the insurance, which we don't have to do with any pediatric vaccine in the state. By the way, nirsevimab is $450 a dose. So how many private offices are going to stock this and have no idea how many people are going to need it? This is competing with the drug called Synagis. Synagis is what we gave through RSV season for high-risk babies, but this is now a universal recommendation. So when it came out, CDC just announced last week that the demand for this monoclonal antibody is higher than was expected. They are asking us to not give it to low-risk babies at this time because there's lack of access to it. They want us to only give it to the highest risk babies. In my state, what we are doing is the hospitals are administering this to the babies before they go home. And in an ideal world, that would be perfect, right? But how many of us have moms who won't even get their kids erythromycin eye drops to prevent gonococcal conjunctivitis? They won't give their babies vitamin K these days. 50 cents intervention that could protect these kids from a cerebral bleed. Nor will they give them Hep B. I can't imagine they're going to give their kids nirsevimab. The other issue with nirsevimab is it's weight-based. And in my state, medical assistants are not allowed under their state, under their protocols in the state, to administer monoclonal antibodies. So the MAs in my office who give vaccines all day, every day, are prohibited from giving this. So the only ones in my state that can give it are nurse practitioners and an RN. We do have an RN, but she's pretty darn busy with lots and lots of other things. So it's fundamentally bringing up a workflow logistical issue. I think it's a great product, but stay tuned. We're going to talk a lot about it more in our immunization update. We talked about RSV yesterday, Shingrix yesterday, now being approved for people who are immunocompromised, day 0 and day 1 to 2 months. And a couple of other quick updates for you. Hep B is now a universal recommendation. All adults in America should be given Hep B vaccine series because of the rates of Hep B in the US. PCV 15 and PCV 20 are now replacing PCV 13. It is your choice which one you want to go with in the clinic, but you don't have to start over. So let's say you gave a baby 2 doses of PCV 13, 2 months and 4 months. They're now 6 months and they're ready to get their next one. And all I have in the clinic is PCV 20. I just pick up where I left off. People think because we add more serotypes to the pneumococcal protection that they're actually better vaccines. Not necessarily. Sometimes when you add additional serotypes, you actually dilute some of the benefit from the older serotypes. So higher numbers is not always better, but stay tuned. We expect PCV 21 and 25 and 27 to hit the US market very soon. Menactra's gone. Menquadphy is now replacing Menactra. That's its brand name, Menquadphy. And if you did not hear this past week, Penbraia got approved. Penbraia is a 5 serotype meningitis vaccine. It contains A, B, C, W, and Y. So it's coming onto the market to be used at the 16-year-old booster. So do you know at 11 to 12, we give kids MCV4, right? A, C, Y, and W. Then at 16, we give them another MCV4. And that's also when we start the MenB vaccines like Trumemba and Bexsero. Now they've put Trumemba into the same vaccine as the MCV4. So at 16, they're going to get 2 of the Penbraias 6 months apart, and it will cut down on one jab, if you will. So that, last but not least about COVID vaccine. So it's now a universal recommendation. It's a monovalent vaccine targeting the XBB subvariant. All of the organizations, the manufacturers have stated that their vaccine is still protecting against some of these other serotypes that are coming out that everyone's talking about. And you may have heard that Novavax, for your patients who are freaked out by the messenger RNA vaccines, Novavax is now approved in the US as a monovalent, same subtype protection, but it's a protein-based vaccine. So people who don't want to do mRNAs, it's similar to a pneumococcal type-based vaccine. It is 12 and older, FDA approved. Questions for me on new drug update?